Hey everyone, welcome back. Today we're going to talk a little bit about extractions. We'll cover when they're indicated, when they're not, as well as impacted teeth and some classifications. Also, we'll talk about some of the complications that can occur during or after the procedure. So let's get started. The most common indication for extraction is a severely carious tooth that can't be restored. If all the decay is removed, there may not be enough tooth structure remaining to place a crown. Also, cases where the caries are reaching the furcation area in multi-rooted teeth would also be indicated for extraction. Another reason a tooth may be extracted is irreversible pulpitis or necrosis of the pulp. Of course, the ideal treatment would be root canal treatment in order to try and save the tooth, but that may not always be possible. For example, a tooth with severe calcification may not be able to be cleaned thoroughly, leading to failure and reinfection down the line. In these cases, extraction and replacement of the tooth could be an option. Another case where extraction might be indicated is a tooth that has undergone root canal treatment and the treatment has failed, maybe even multiple times, and the patient no longer has the time or money to get another retreatment done. Severe periodontal disease can lead to bone loss and eventually extremely mobile teeth, which would need to be extracted. So if the patient has plans for implants in the future, teeth with severe periodontal disease and rapid active bone loss that are not responding to periodontal therapy should be extracted in order to make future procedures easier, as a healthy amount of bone is needed for implants. Otherwise, they may need to undergo additional procedures like bone augmentation before implants can be placed. In cases of orthodontic treatment for crowding, teeth may sometimes be extracted to make enough space for the rest of the teeth to be aligned. The premolars are the most commonly extracted teeth, with the first premolar specifically being the most common. Some teeth are malpositioned in the oral cavity and should be removed. Examples could include upper third molars, which are causing trauma to the cheek, and also super-erupted teeth in cases where the tooth in the opposing arch is missing. Cracked and fractured teeth, depending on the extent of the fracture, may also be extracted. In teeth with multiple roots having a fracture in one of the roots, root amputation may also be an option in an effort to save the rest of the tooth. Impacted teeth that are not expected to fully erupt are also indicated for extraction. There's a debate on whether or not to extract fully impacted teeth if they're asymptomatic, but for partially impacted teeth that are either causing trauma or inflammation to the mucosa or pushing on adjacent teeth, these should be removed. Also, supernumerary teeth, the most common example being mesodens, which is a supernumerary tooth present in the midline between the central incisors. Some pathology, especially cysts and cancers, may include the tooth, and these teeth may need to be removed in order to fully remove the lesion or to make sure that the lesion does not reoccur. Patients who require radiation therapy for oral cancer or head and neck cancer should consider removal of teeth that may be in the path of the radiation and are either carious or periodontally compromised and may end up needing to be extracted during the period of radiation therapy. This is because extractions can be traumatic, and trauma can increase the risk of osteonecrosis of the jaw during radiation therapy. In cases where a patient needs an extraction and they're undergoing or have gone radiation therapy, hyperbaric oxygen therapy before and after the extraction may help to prevent necrosis of the jaw. The same would be the case for questionable teeth before cardiac surgery, transplant surgery, or before starting bisphosphonate therapy, as having to extract a tooth following any of these carries many different risks. Now the contraindications. Patients with uncontrolled diabetes, as they are at a higher risk for infection and have slower wound healing. Patients with advanced or uncontrolled renal disease and cardiac conditions. Patients with leukemia or lymphoma, as they are at a higher risk for infection. Patients with hemophilia or platelet disorders, as their condition means an increased bleeding risk. Patients undergoing radiation therapy, as I mentioned before, they're at a risk for osteoradionecrosis. Patients receiving intravenous bisphosphonate treatment, as they are at an increased risk for bronch, which is bisphosphonate-related osteonecrosis of the jaw. Teeth that are in an area of a tumor or patients undergoing chemotherapy. Third molars with severe pericoronitis, as extracting it has high risks of complications. Once the pericoronitis has been treated, the tooth can be extracted to prevent reinfection. As for pregnancy, it's not an absolute contraindication. Ideally, the patient would go to the dentist before trying to get pregnant for a checkup or after delivery, but in any case, the second trimester is the safest time during the pregnancy to get dental procedures done. Now let's talk about impacted teeth. A tooth is said to be impacted if it doesn't erupt within the expected time, and the main cause for a tooth not erupting is insufficient arch length or insufficient space in the arch. There are many reasons why you would want to extract an impacted tooth. An impacted tooth can lead to periodontal disease and caries, as well as to the adjacent teeth, due to it becoming difficult to clean in the area of the impaction. Cases of pericoronitis and impacted third molars, especially if there's a recurrent infection, should indicate extraction. In some cases, especially when the impacted third molar is angled towards the second molar, it can apply pressure on the roots of the second molar, causing external root resorption. If you can see in the X-ray here, the third molar is horizontal, with the crown facing towards the roots. If it continues to grow even a little bit, it would be pushing against the roots, and that may lead to resorption. And of course, extracting impacted teeth may be required during orthodontic treatment. Another thing you should know, which can come up on exams, are the most commonly impacted teeth. The most commonly impacted are mandibular third molars, followed by maxillary third molars, followed by maxillary canines. There are also some situations where you would consider not extracting an impacted tooth. These would include a patient who has had the tooth impacted for many years without any disease or pain and is older, usually older than 35. This is because as patients age, the bone in the jaw surrounding the impacted tooth becomes more calcified, making the extraction more difficult as more bone would have to be surgically removed. Also, an older patient would have a more difficult time dealing with the post-operative recovery compared to someone younger. So as long as there's no indication of disease, the impacted tooth can be left alone and monitored periodically. Another contraindication would be a medically compromised patient with an asymptomatic impacted tooth. If the tooth does become symptomatic at any point, you would work with the patient's doctor to come up with a plan to safely remove it as soon as possible. One last situation where you may consider not removing an impacted tooth is if it's very close to a structure such as a lower third molar being very close to the inferior alveolar canal, where removing the tooth would most likely damage the nerve. Of course, it all comes down to whether the tooth is symptomatic or not, as well as the expertise of the dentist or surgeon when deciding whether to extract it. Now let's talk about some classification systems for impacted teeth, and these classifications are primarily used for third molars. Classification of impacted third molars can be useful when communicating with other dentists, as well as assessing the degree of difficulty of the extraction. The classifications that we'll talk about require looking at an X-ray, specifically a panoramic radiograph, which is the best choice when planning to extract impacted third molars. In cases where the roots are very close to, or even superimposing a vital structure on the X-ray, a CBCT can be helpful in determining exactly how far the roots are. And for each one, I made a little sketch. Just don't judge. The first classification is Winch's classification, and it's based on the angulation of the third molar, specifically the angle of the long axis of the third molar in relation to the long axis of the second molar. In the first picture, we have a vertically impacted tooth, where the crown of the third molar is parallel or almost parallel to the second molar. Next is a mesioangular impaction, where the third molar is tilted mesially towards the second molar. This type of impaction is the most common, as well as the easiest to remove for lower third molars and the most difficult to remove for upper third molars. Distal angular impactions are when the third molar is tilted distally away from the second molar, and it's the opposite of mesioangular, as these are considered to be the most easy to remove in upper third molars and the most difficult to remove in lower third molars, as the path of removal is essentially towards the ramus, as well as the roots of the third molar being very close to the roots of the second molar when it's in this angulation. Next, we have a horizontally impacted tooth, where the third molar is perpendicular to the second molar. Besides these, there are also some more rare angulations, such as a tooth being impacted upside down, or a transverse buccolingual impaction, where the occlusal surface faces the buccal or lingual direction. Next, we'll talk about two classifications, both proposed by Pell and Gregory. The first one classifies the third molar based on how much of the tooth is covered by the bone of the ramus. There are three classes, with Class 1 being the easiest extraction, and Class 3 being the most difficult. A Class 1 impaction means that the mesiodistal diameter of the crown of the tooth is anterior to the anterior border of the ramus. In other words, the crown of the tooth is not covered by the bone of the ramus. If half or approximately half the crown is anterior to the ramus, while the other half is posterior, then it's a Class 2 impaction. If the crown of the tooth is completely within the ramus of the mandible, it's referred to as a Class 3 impaction. The second classification of Pell and Gregory looks at the relationship between the occlusal planes of the third molar and the occlusal plane of the second molar. This one also has three classes, with each one being progressively harder to remove. Firstly, we have a Class A impaction, where the occlusal surface of the third molar is at the same or nearly the same level as the occlusal plane of the second molar. Class B means that the tooth is impacted more apically, with the occlusal plane of the third molar being between the occlusal plane and the cervical line of the second molar. And lastly, a Class C impaction means that the occlusal plane of the third molar is below the cervical line of the adjacent second molar. The last thing we'll talk about in this video are some complications that can happen during or following an extraction. An oral antral communication is an exposure between the oral cavity and the sinus, and is clinically seen as a black hole. The management depends on the size of the opening. For smaller openings less than 2 millimeters in diameter, a collagen plug with sutures can be used, and you just need to give the patient instructions. These include no poking the area, making sure to open the mouth when sneezing or coughing, no using straws, no smoking, and no blowing your nose for at least 1 month. For an opening between 2 and 6 millimeters in diameter, a collagen plug should be used to stabilize the clot, and figure of 8 sutures should be given. In addition, the patient should be given antibiotics, antihistamines, analgesics, and Afrin, which is a popular brand of nasal decongestant. You can remember these as the 4 A's. For a larger opening that is more than 6 millimeters in diameter, it will need flap surgery to achieve proper closure. If excessive apical force or improper technique is used, the tooth or roots can be displaced. What you should know are some of the most common sites where teeth or roots can be displaced. Maxillary molar roots can be displaced into maxillary sinus. Maxillary third molars can be displaced into the infratemporal fossa, and mandibular third molars into the submandibular space. In cases of a maxillary tooth being very close to the sinus, or if the sinus floor is very thin, it's possible for part of the tooth or root to be pushed into the sinus. If a tooth or root tip does get lodged in the sinus, you should first try to remove it with a suction tip if it's a smaller piece. Otherwise, a surgical procedure involving a flap and removal of the bone to access the sinus should be performed, which is referred to as the Caldwell-Luck approach. Dry socket, also referred to as alveolar osteitis, presents as throbbing pain, usually 3 to 5 days after extraction, as a result of the loss of the blood clot that was formed. There are many factors that can contribute to this, such as the complexity of the extraction, whether the patient smokes following the procedure, and oral hygiene. Dry socket rarely occurs in the maxilla, with almost all cases being in the mandible. If a patient comes complaining of dry socket, irrigation and placing a medicated dressing usually containing eugenol provides relief. Every 24 to 48 hours, the socket should be irrigated again, and the dressing should be changed until symptoms disappear. And antibiotics are in general not needed for cases of dry socket. Another possible complication that may arise is nerve injury. When extracting mandibular molars, the inferior alveolar nerve is the most commonly damaged, followed by the lingual nerve. Extracting lower premolars can also damage the mental nerve. This kind of injury can cause a tingling or numb sensation, known as paresthesia. To treat inflammation, steroids may be prescribed, and it's crucial to monitor the patient closely because sensation may return, but if the numbness persists for more than 4 weeks, nerve microsurgery should be considered and the patient should be referred. Other complications include bleeding, infection, damage to adjacent teeth restorations, jaw fracture, or air emphysema. Air emphysema can occur when air from the use of an air-driven high-speed handpiece, when removing bone in the case of extractions, is forced under pressure into the soft tissues, which can lead to swelling. This can be avoided by using surgery-specific handpieces, which are either electric or blow the air in a different direction away from the tissues. Alright, that's it for this video. As usual, if you've got any questions or ideas for what I should cover in future videos, just drop them in the comments below. And make sure to like the video and subscribe, because I'll be putting out a lot more content soon. Thanks for tuning in, and I'll see you in the next one.